Can you see the slides?
Yes.
Yes.
Ahmed? Yeah, sweet. Right, this is the only slide that actually has some detail on. The rest of it, I do it on a beautiful white background, so that it's for clarity only. So, so Miss N, right? She's a lovely lass, 30 years old, nulla paris, normal BMI, low risk combined screening test. Susanna, don't worry, she's got normal uterine artery Dopplers, yeah? VT0, not eligible for aspirin, serology negative, absolutely don't want to see her in the antenatal clinic. Crack on and be normal. Right? However, at 36 weeks, she presents with reduced fetal movements. And so a CTG is performed, which is normal and appropriate baseline. However, it's found the baby's on the 15th centile with a decreased growth velocity from the anomaly, but normal Dopplers and Leica volume. The plan is for CTGs 3 times a week and to repeat the Dopplers and Leica in 1 week. They turn out to be normal, and then a repeat growth scan at 38 weeks demonstrates that actually baby's growing normally, fluid is borderline normal, and normal Dopplers. So therefore she falls back into the low risk category as per the notes and consultant appointment. At 41 plus 2 weeks gestation, she's referred by the midwife in clinic to DAU with a history of reduced fetal movements, borderline blood pressure. There's no symptoms of preeclampsia, no protein in the urine, and her preeclamptic routine bloods are normal. A vaginal examination in clinic found that there was just a dimple-like cervix, unable to perform a membrane sweep. But the midwife is absolutely adamant that there is definitely membranes intact. Fetal heart rate in clinic was 130. So she comes to DAU. And this is the CTG. It meets Dawes Redmond. It's 10 and 16 minutes. How does everyone feel about CTG? Right. Remember, she's not in labour, it's alive. No concerns about baby there. There's some fetal movements on the CTG, and I've said it met Dawes Redmond. Blood pressure in DAU is within normal range. And actually, when asked about fetal movement, she says actually they're fine, to be honest. But given the context and just not everything being a bit suboptimal, she's offered induction of labour at 41 plus 2 weeks. She goes home and comes back at 5 p.m. to start her induction. This is the CTG. Tightenings on the antenatal ward, probably because the little... Any thoughts on the CTG now?
It's been a rising baseline.
The next one is the one here. Or following thing. So the question is fit for protest. It's met Dawes Redmond criteria. So the feeling here is, yeah, sure. So
She seems to be concerned.
She's having some mild uterine tightening. She's not requiring any analgesia. She's very comfortable, and it's just because somebody played with a dimple cervix earlier in the day. And so on that's the pre-ProPES CTG, and so she's given ProPES. So Bishop score is 3, and ProPES goes in at 8:30 at 6:30 at night. I can't tell the time. Post ProPES CTG, so she's still having that uterine activity. Baseline is 140. It's accelerative, and she does describe good fetal movements. A routine CTG at 6 hours is performed, and also at the same time she's requesting pethidine now because she's started to develop more significant contractions. And so the pethidines given, and this is the first 20 minutes of the trace. Fit for pethidine. Side, and the trace is continued. The trace is continued, and a doctor review is reparations. Ongoing decelerations, and a doctor comes into the room. Now, I think you guys, your video is in the way of the good stuff, so I'll just move you over there somewhere. So, reviewed by the doctor, and the ProPES is removed, stating that the number of contractions is significantly more than what is the CTG picking up, and there's significant deceleration. Sorry. It continues, and so terbutaline is also given. So ProPES out at 250, which is about 7 hours post it being in. A VE at the time of taking it out showed that she was 1 centimeter fully effaced. Terbutaline given, and there's a plan to move to labour ward, cannula, and ARM if contractions from the note. So this is the trace ongoing. So you can see terbutaline has just been given, and we're much happier with the trace now. Contractions still continue. So now she's on labour ward. It's about an hour after giving the terbutaline. Are we happy with the trace again?
Yeah.
So review on labour ward. So the trace is said to be contracting 3 and 10. Heart rate's now 150. Very good variability, no accelerations. Occasional decels below less than 50% of the time. in 4 hours, and inform the doctors if any increase in baseline.
Okay, can I stop here? You need to go, so I can't stop you. Continue.
Yeah, I mean, yeah, gynae. Yeah, think about gynae. So
yeah, I know. I won't stop you.
If you want to say Susanna, I mean, you can.
No, don't. Otherwise, the gynecologist of my team will be against me. No, there's one thing that I want you guys to just go one slide before. So I think that one of the things that is coming on the cases that I have been reviewing is a lack of consistency on our language. Please be consistent. So you need to put your thought, what is this baby telling you? So you need, when you classify the CTG, you need to say, what is the baby normalizing from? What is this normalizing, yeah? So what is this baby telling you? It's telling you about placental reserve, isn't it? But I don't want to interrupt now, otherwise just continue, Adam, continue. Please continue.
I've totally lost my flow, Susanna, I don't know.
I'm sorry.
Okay, so this is the CTG on this is the CTG on labour ward as it continues. This is now 3 hours post terbutaline, ongoing contractions. Doctors are aware. Labour ward is very busy at the time. So continuing to contract on now 4 hours post terbutaline and VE.
Can I just stop you there for a moment, Adam? Before this starts happening. So 4 hours post terbutaline, the terbutaline should have now completely come out of her system. Yes. The baseline is still 150. Variability is fine, but there are still decelerations. Remember what I said? So when she's starting with subacute hypoxia or thing, then she just literally just jumped a step because of terbutaline that we gave her. But the baseline now is slightly higher It's not gone through the, I'm losing cycling, I'm doing all that kind of business. It's literally just jumped up to, I actually still have a high baseline.
I mean, it's pretty crap, isn't it? So membranes intact, not in labor, 2 centimeters, didn't like the ProPES. You know, it's not looking very positive for this 30-year-old primate who was low risk. So I'm trying to think. So come 6:30, and then we ask for a doctor's review. I think that's quite sensible. And so doctor review of VE at 6:30. She's 2 centimeters now, fully effaced, membrane scribed is 5 and 10. Again, not all the contractions are being picked up on the CTG. Baseline is 150 with good variability, but there's no accelerations and there's proper loads of variable decel. So it's described as an abnormal CTG, and the plan is for tributaline, and she's in quite a significant amount of discomfort, so it's to consider an epidural. So this was at 6:30 that we examined her. So let me just.
Do you agree with the assessment?
This is 6:30.
Shall we go back? Do you guys agree with the assessment?
So. Oh,
Is it almost a subacute there?
so I'm only going off the notes, so about what's going, but the considering, and I don't know the human factors going on there, but the consideration of an epidural at this particular situation could just add another stress, such as hypotension, to an already compromised baby. No, what do you guys think?
So,
Yeah.
Guys, yeah. Okay, go ahead.
We haven't got to the end yet.
no, we haven't got to the end. I know that, but we're saying that there's a rise in baseline. Do we think that virility is normal? Do we think virility is more than 5? So, as a rule, if you're squinting at the virility to figure out whether it's more than 5 or not, it's reduced. Okay. If you're squinting at it to figure it out, it's reduced. So this baby is starting to decompensate.
So this looks like, subacute hypoxia. You're getting widened D cells, deeper D cells. And so we're giving her some tributaline and consider an epidural. And this is
the effect of the epidural.
This is after the tributaline, prior to an epidural. Yeah. So I'm much more happier with that. So yeah, now that we woke them up, allowed the CTG continue, and then we learned over as well, and it was a very busy labor. It wasn't me on, but scary phrase. Going on, so now we're at 7:30. She gets an epidural at 7:30, so this is the trace preceding an epidural. Then it's at handover time.
160? Why is the baseline still 160?
Baseline, 150, 160. I'm happy with the variability. Patient's happy because she's got an epidural. And we even got now maternal heart rate as a treat, which is 105.
Okay.
So ongoing, so baseline is still raised, ongoing decelerations. It's now somebody else's problem because it is handover time. Probably suggest to go see them first. Ongoing. Still not a great taste. So you've got these kind of more shallow but prolonged decelerations now that are lasting like over 2 minutes.
Why do you think it's taking longer to recover?
Going on all the way to 12. So there was no elective doctors at this day. So the labor ward team decided just to sit on this patient, observe the CTG, examine her 4 hours after the last examination, and then see how it goes. So then we examine her at 12:30, so just before, after this CTG. And we said, well, we've got to do something, suck it and see. So we ARM, and there's just thick pea soup meconium coming out of this poor woman. and she's 3 centimeters, very little change from the previous examination. And so you can tell when we ARM because we put Stan on at the same time, and you get these significant decelerations. But she's also on her back at the same time. So then she's turned onto her left side.
Let me stop you there. Let me stop you there. Can we put Stan? Is she suitable for Stan?
No.
Why not?
You should start it on a normal CTG.
So yeah, this baby is already showing signs of hypoxia. You can't start Stan when hypoxia is already there. Yeah, because it's going to take that the normal for this baby is actually hypoxia.
Okay, guys, I think that this CTG needs a really big reflection. Okay, I'm hoping that the reason I have not seen this in risk is because someone came in, did something good, yeah, which is to deliver this baby. But
we did sorry,
don't tell me what you did, because you know, I just want people to reflect on what is happening. So when we say about types of hypoxia, it's also about a journey. And where in the journey you are is very important. Yeah. So this baby is telling us from the beginning, I have a very poor placental reserve. That's what the baby's telling you. The baby's telling you, I have a very, I started well because at rest, I can cope. But anything happens and I'm off the curve, yeah? So this baby's telling you it's a very low placental reserve. So I think that when you look at the CTG, we need to look where in the journey we are. Go one back, please. Go one slide back, please.
So
before the ARM. Even before the ARM.
So this is before the ARM?
Okay. This is before the ARM, okay? So when you are here and you say, okay, you have someone that is not in active labor, the baby's telling you, I have a very poor placental reserve. Now this is the time to question, am I fit for labor or not? And remember, the uglier the decels, the better it is. Because the uglier the decels, the better the fetal response. So are these chemo or baroreceptor decels?
These look more like chemoreceptor, yeah.
Chemoreceptor decels, yeah? And you are 2 centimeters in labor. Okay, and you have given terbutaline, so it's not hyperstimulation, because sometimes you can have this picture so you are now with the right amount of stress of early labor, and you have the CTG. This is the step 1. Is this baby fit for labor or not? And if you are relying on Stan for this, is even worse. Because you get into trouble. Yeah? Sorry, just continue.
Yeah, no, it's completely appropriate. So from what I remember, there was a long discussion prior to ARM about whether to proceed or not, given what we were thinking. And so the MDT approach was to ARM. There was absolutely no decision to put a Stan clip, to start Stan. It was a decision for a fetal scalp electrode. Stan was started as just an automatic, still 3 centimeters, contracting, and the decision here is for a FBS. Let's do a fetal blood sample and to see what's the little scratch. We can get to the head now, past the meconium. So the decision is for a Cat2 cesarean section for a combination of factors, but with an underlying concern about placental insufficiency, not fit for labor or to start oxytocin, and actually not progressing. So. And so emergency cesarean section at 1 o'clock, chopped baby out within 50 minutes, 2.9 kilogram baby, which interestingly is the estimated fetal weight that the baby was at 38 weeks. Gases were taken, but however, they're just absolutely not in the notes, unfortunately, but verbally stated as normal. And the placenta was proper amazing. So it was so calcified, it was crunchy, like you could snap it in half. Like it was so cool.
So disgusting.
So it just looked like everybody went to go touch it and play with it. And for what it's worth, we did send it for histology to see if it would, lead to anything for future pregnancies, but it's unlikely to show anything valid. Overall impression, the baby had poor reserve, and that was evidenced by, as people have already said, baby happy at rest, but as soon as you put a stressor, there was a rise in heart rate and significant decelerations. Placental insufficiency was suspected, given that she had hypertension, reduced fetal movements, and so thick meconium that there couldn't have been much liquor there. And being aware that meconium increases the risk of not only hypoxic injury, but also infection. And so the questions that it raises: was this baby fit for labor? We've talked about the fetal heart rate being 130 in day assessment unit. Throw in some contractions after the sweep. Baseline raised to 140 with decelerations, and then significant decelerations with propess and rupturing the membranes, and the significance of meconium and whether hypoxic stress can lead to meconium. The evidence is conflicting. I'm sure Ahmed and Susanna will have something to say about that. Already suboptimal hypoxic and infective stress. And so I just thought I would ask, is there anything that you would do differently, or how we could improve the management?
So just out of interest, as you mentioned it along the way, do you think if you actually FBS that baby, do you think the gases, the FBS would have been helpful?
I wouldn't do it anyway because it was in meconium, which would lead to a
what? It's just the meconium that is stopping you, Adam.
No, but you can't do it when there's meconium. Like,
Strangle you. Come over and strangle you.
So meconium can give actually a false positive or a falsely raised pH, and so because of that, I told the consultant that we should stop
FBS.
FBS. Yes.
So interestingly, as I said, we could see from this trace that the baby had chronic hypoxia. We could see that from this trace that the baby was decompensating. FBS would have actually probably gotten us to maybe even start Synto on her at 3 centimeters and ended up with a crash baby or a really, really damaged baby. Do you think we could have delivered this baby earlier?
This was definitely discussed. I think there was a number of human factors going on as well, but it was discussed quite frequently. But it was always felt that the CTG was not pathological to do an emergency cesarean section, and it was a discussion in the MDT about where do we go from here with a very low threshold for cesarean section. I don't know what everyone else thought.
Go back to the trace at 6 o'clock in the morning.
I tell you a learning from looking at lots of risk cases from the past and from other units. The babies that do really unwell, people look at the CTG, and at the time, the CTG was not that bad. You know why the CTG is not that bad? Because this is a baby with lack of capacity to respond.
Yeah.
And the problem then is that it's not that bad until it's too bad. And the babies either have neck aspiration, hypoxia, HIE, or death. This is the risk, guys. And that's why that step one, it's very important. So this is a baby that didn't present with a typical thing of chronic hypoxia on the CTG, but could show very clearly in the beginning very poor placental reserve. So still the first thing applies, is the baby fit for labor? The steps of gradually evolving hypoxia, where you see very ugly CTGs and you say it's fine, they need to start well. They need to start well, and they need to show that those are the runners. Those are the ones that can go the marathon. It's not the ones that are already huffing and puffing. You have not started the initial line. And this is a very, very important learning, because you need to look at the CTG within the journey. Where in the journey are you? Are you 2 centimeters or 8 centimeters? And what is the baby telling you in terms of capacity to respond? This baby started with chemoreceptor V cells. Yeah? Okay, sorry, I tend to speak too much.
So, I mean, I even struggled. So I was the one who, I don't mind people knowing that I was the one who saw her in MAU to make the decision for induction. And then I came on in the shift in the day. And I had to put up a debate about actually inducing her. Yeah, I had to make the decision about even inducing her because her blood pressure was normal. Her movements actually, when I asked the binary, are they changed? Actually, they're fine, to be honest. But they just, everything was a bit suboptimal.
But that is the most common story for reduced reserve, Adam. Reduced reserve is a spectrum. Not everybody comes with reduced fetal movement. So the decision for induction was right.
Correct.
Yeah, but actually it was hard to validate with the patient because I'm like, okay, blood pressure is normal. She's like, oh, actually the baby movements are fine. And then I had to kind of...
He was post-dates anyway though, man.
Yeah, I know, that's why I was like, come on, mate.
With a small baby.
Yeah, I mean, her baby was normally growing at 38 weeks. Yeah, I mean, the scan is, yeah, who knows? I mean, it is definitely a small baby. I mean, by the ultrasound standard, it hasn't grown in 3 weeks. But, and then, yes, we always talked about, should we deliver this baby throughout the day? So from 8:30 onwards, it was like, should we deliver this baby? It's clearly placental insufficiency. Yeah. And I mean, in retrospect, you can see that we sat on it for a long time. But I tell you, a lot of individuals were involved in the decision making. You know, this is not one rogue person. this is a lot of us around.
We're not here to criticize the management, Adam. We're here to see whether.
I'm explaining also that, you know, this is about people. Everyone kind of had a thought, and you're completely right, Suzanne. Everyone was like, it's bad, but not that bad. And the question is,
so, yeah. And that's what I want to challenge you as is about how is the fetus? What is this telling us? It's not about the CTG being bad or good. Is what is this baby telling me? How is the fetus is the question, yeah? What is this baby telling me? And this delay in things is because we haven't done the diagnosis. Once you do the diagnosis, the action follows. We haven't done the diagnosis. That's the problem. And then we kind of blind ourselves with human factors, or it's busy, or it's not busy. Because if we know that no busyness that stops us to act, yeah. So I think that we got a way long journey in terms of recognizing chronic hypoxia. I think that probably one of the focus for next cycle and next year, because that's what me and Ahmed are preparing for, kind of the teaching and the training for next year, is about how to recognize full placental reserve and these subtle things. Yeah. But well done, and thank you so much for presenting this, because I think it's a huge learning.
So the question for people would be: Would you have ARM'd at the CTG when you're regardless of what's happened? If you can see it here, this is.
Let me comment at the 6 o'clock CTG first. Sorry.
It's hard to. I'm going this way, yeah, or this one.
So just the one before that, yeah. No, the one before that, yes. So you can see the baseline here is about 150, yeah, 150, 145. If you go on to the next slide.
I went the wrong way.
Yeah. So all it took was 2-3 contractions. So can you see that at 6:23? So the beginning. So there's 1, 2, 3 decelerations, and then the baseline goes up and the variability goes off. So this baby took 4 contractions to make this baby decompensate. Okay. This is a baby it's not just about showing you poor reserve, it's actually reaching its limits. So the only thing I would do differently. So if it was me, and I'm thinking again, I have the retrospectoscope, yes? I'm sitting here in the comfort of my chair and making the decisions. It took 4 contractions for this baby to decompensate, and she's only 2 centimeters. And we're approaching handover time, which is always a very dangerous time. Terbutaline was a perfect medication to relax those contractions, make sure this baby's fine. But the question, as Susanna was saying, is this baby fit for labor at this point? So this would have been probably the section that we would have been in while one of the registrars in theater, while the others were actually handing over. Does that make sense?
And when you think about ARM or epidural, then it means decision not being made. Yeah. Because, and that's why most of our risk cases happen at handover. I think that is a combination of delaying decisions because, and then handover time is not a half an hour. Between you hand over and you go to the room and, there's too much. And it's a theme with us, this handover time, but it's a combination of delaying the decisions and the busyness, and that happens at handover. So why would I not ARM'd? Because it wouldn't make no difference. Because I made the diagnosis already that this baby is not fit for labor. So ARMing is going to increase the stress. So instead of doing a calm section, I would potentially be doing a cat 1 if suddenly goes off. So I wouldn't ARM because the color of the fluid wouldn't change my decision. I mean, just came to confirm what it is, but it wouldn't have changed it. And the other, that you wouldn't see any fluid, which sometimes it's the case. You ARM and there's no fluid. Where is it? And the other thing is the epidural. If you make a decision, then epidural is just going to delay things. It's going to be an hour before the epidural, plus a bit of more maternal hypertension, plus, So the problem here is the same thing with the fluids in the past, or give fluids. Give fluids is not the problem of the fluids. Is not making a decision. And we don't make a decision if we don't make the diagnosis. So it's about making the diagnosis. And that is, I think, the root. And, at the end, understanding the CTG and not that. And I would like us to be very consistent in the language we use. Maybe we need to introduce this placental reserve of something. I don't know. We need to think about it, Ahmed. But this thing of normalizing, better, improved from what to where? Yeah. So, and the other way that may help you is to think why am I doing it? What do I expect to see? So ask yourselves, okay, why am I doing an ARM? What am I expecting to see? Why am I doing an epidural? What am I expecting, or what am I risking? Keep this kind of a questioning ourselves. So you always have in the background, how is the fetus and what am I aiming with this? Again, speaking too much. Sorry. Are you still there?
Yeah, no, we're all here, and I think it's a great case to discuss. Yeah. Yeah. Sorry, Ken.
The other thing that so this is a learning point that I had from another hospital. So on this trace, the tracer you can see at the moment, be very cautious when she gets her spinal. So this lady had her terbutaline, settled the trace first. Did you see that? So yes, we can see signs of decompensation. If this lady gets a spinal anesthetic, the moment she gets the spinal, this baby's going to crash. Try and settle
If he
this
gets an
baby.
hypertension with it.
Yeah, but they inevitably always get a degree of some hypotension.
Yeah.
So just because that I've seen from several hospitals. I've been asked about. You can see signs of decompensation already. They've decided, but I'm not going to give tributylene because she's going to bleed. No, she doesn't bleed. Give her tributylene and then take her to theater. So settle this before, so that she doesn't decompensate further with the spinal.
And there's another thing that you can do. Potentially, you know, I'm a little. So I think that, you know, it's good to discuss case with you, Ahmed. I think you use more tributylene than I use. But what I would definitely do in this case is to discuss with the anesthetist and preemptive the anesthetist to say, and the neonatal team to say, I'm expecting this baby to be well, but this baby has very poor reserve. Anything that tips off, like positioning on the table, yeah, or spinal, even if they don't are hypertensive, they have a huge vasodilatation in the lower limb. So, you know, the part of the uterus, that the part of the blood that is supposed to go to the uterus is diverted to the legs of the mum. And babies that are on the edge, changes in perfusion, a uterine perfusion, then can tip them off. And then you are doing a cesarean section with an acute hypoxic stress on top for reduce one, because, and risking neck aspiration, HI, etc., because the capacity to compensate is nil. So discussion with the pediatricians, discussion with the anesthetist to say, preempt her with fluids, because we want at maximum cost avoid maternal hypertension before we do the section. Yeah.
I think that's all we have time for.
Very good. Thank you, Ahmed. Thank you, Adam.
Thank you very much, Adam.
Thank you.
Thank you very much, guys, for joining.